I think we want to make a slight adjustment to the agenda order this morning. But if Emma, if there are any administrative comments to make at the start concerning privacy and so forth.
Thank you, Chair. Just a reminder that the public section of the meeting will be recorded and published online for public access after the meeting. Can all attendees mute their microphone when not speaking, please? And we have apologies from June Brown, who will be joining at 11, and Luann Grujon is substituting for June. Thank you.
Great, that's good. Welcome, Luann. Good to see you. Let's get to the agenda in that case. And as I just mentioned, I'm proposing that we do a slight adjustment. Paul has another pressing meeting. So 6.1 is financial monitoring. Who do we move that to just after 3.2 business planner? Would that be helpful, Paul? Yeah.
Yeah, that would be okay. Thank you. Yeah.
Are we okay with that, everybody? Yeah. Okay. Great. Okay, let's go through the business. Are there any declarations of interest or transparency statements? No, I don't see any. We don't have any exempt business. The minute of the previous meeting is included there. Does anyone have any problems with the accuracy of the minute, or can we agree it as a true reflection of business transacted? We're all okay with that. Great. And the business planner, item 3.2. If we could go through that now.
Yeah, I'll take you through that one. The first half a dozen roll papers on the agenda for today. There's a few highlighted as being deferred or removed. There was one on the Navigator project. We've asked for a deferral of that one just due to capacity in the service to actually do the report. Whistleblowing update, there's none for this time. The CAMS update, we're still waiting for the information to come for the report, for the basis of the report. So again, we've asked for that to be deferred. The self-directed support, we weren't sure what was happening here with this one, whether it needed a report or not, but on Claire's checked it, we're actually just going to add on some information to the dashboards on the SDS outturn stuff. And the last two, the annual review of the RAPC and the review of the financial governance, there's several links and references back to the full year end and the MTFF. So we've asked for this to be done after the year end to come to the May committee rather than the April committee. Sorry, the February committee. So we've asked for that to be deferred. And those two reports, it's the same. If you scroll right down to the very bottom, they're actually in for the March 24 committee as well, but they'd be carried forward onto the May committee whenever the dates come out.
Okay. Thank you very much. I think that seems entirely reasonable with those items 16 and 17 to move them to after the year end. So is everybody okay? Luann.
Thanks, Martin. Just a point for clarification from me on the whistleblowing, where we've got no reports for this committee. Is that whistleblowing reports around the IJB policy, or is that any whistleblowing activity for our partners? I see Martin Allen's just appeared on the screen. Martin, just to remind me of what that means. Thank you.
Yeah, thank you. Through you, Chair. Yes, it would be the IJB whistleblowing policy as well as the Council and the NHS as well, but there's none for this reporting cycle. Thank you.
Happy with that. Thanks for that. And then John.
Thanks, Martin. Yeah, it was just a quickie on the deferral of the Navigator evaluation to May. Obviously, we'll be doing the budget for next year before that report comes to us. Given that I totally get the capacity issue, so it's not a criticism, but can we have assurance that if it turns out that the Navigator project actually is doing what it set out to do and actually is pretty good stuff, we would still be able to continue to fund it going forward, notwithstanding the fact that we're doing the budget before we get the evaluation.
Yes, there's no adjustment in the budget for taking anything out of the Navigator project this year. So
Thanks, just wanted to check. That's great. Thank you.
Okay, thanks for that. And could I just go back to line 14 on the CAMS update report? I mean, there's a lot of important joint work underway on mental health and well-being. Do we have a precise timescale for when that will come back?
What I was told there is they're still waiting for the information to come back that they're basing the report on, and it was delayed from the last committee. So I'm hoping it's going to come to the May committee as well. But they are chasing up the data.
Okay, thanks for that. I mean, it would be really good to be cooperative to partners and so forth if we could make, do what we can to ensure that comes forward. Important work there. So thank you for that. So that was the business planner. Everybody happy to note that? Great.
Yeah.
In that case, we can go on to 6.1. Over to you, Paul, if you'd like to introduce this.
Yeah. So this is the monitoring for Q3 up to the end of December. We're still forecasting to be on budget for the year. There's several variances you'll see on appendix the first appendix A. There's several variances over and again up and down, but at the end of the year we're all balanced out. There's the variance analysis and the notes behind it are in appendix B, and we've got some environments that we'd like a committee to approve on appendix F. Are there any questions?
Do we have questions? I mean, there are quite, just mentioning it, appendix B, those are quite significant variances in both directions for primary care prescribing, significant overspend, and then the significant underspend with primary care services.
Yeah.
In the end, as you say, it balances out, but I think these are quite important to note that there are quite significant developments underway.
The prescribing overspend, that's the meeting I'm going to after this one at 11 o'clock to discuss that, because there is pressures on that across the whole system. And the underspends in primary care, they're mainly one-off savings for a rates rebate. And again, we're obviously balancing out the two there. The other ones, they're within a few $100,000, but again, the balance out, the out of care placements. Again, we're looking at that for next year's budget to try and take some of those people back into our own authority to save some money there.
Yeah, that's helpful. So fortuitously, you're going to the meeting that will discuss the prescribing issue. Will there be reporting back on that? Will there be action following that?
I'm hoping so, yeah, because like I said, we're looking at this. There's a big pressure in for next year's budget for all three IGBs and the NHS on prescribing. So that's what we're going to be looking at. I don't think there's anything that's going to change this year's outcome. So the 3.2 million will still be there for this year. It's more for what we can do for next year to mitigate it.
Yeah, well, I think it's good to have that long-term strategic view, because it's an area where we want, as far as possible, to control where it's reasonable to manage the expectations and the resources on that. So thank you for that. Does anyone have any questions on this financial report? Luann.
Thank you, and thanks, Paul. Just a few questions from me, probably daft questions, but it's never stopped me before. The primary care services, the overspend. Can you just tell us a little bit more about what that actually is? Because I suppose in my head I think of general practice, independent model. So where's the overspend? So that's my first question. On the prescribing budget overspend, Is there any, are we able to look at if there's any evidence of over-prescribing or is it all about drug costs going up? And my third question is about care home sustainability payments being quite significant. I just want clarity that I think I'm understanding that'll stop, that payment that ends at the end of March. So what's the risk for care home sustainability beyond March and how that's being looked at? That's my three areas that I'd just like to hear a bit more about. Thanks, Paul.
Okay, I'll try and get these in order. The primary care, the overspends, there's several overspends in here, but the biggest one's on enhanced services. But again, it's all balanced out within the year. It says in the, on note H, there is overspends on enhanced services. What was it? Sorry, the prescribing. Yeah, the prescribing one. What's happened there is it's the average price has gone up and the number of prescriptions has gone up. So this will be the first time I think we're hitting the 10 million prescriptions for the year. And with the average price going up, that's what's increasing the overspend. So again, that's what we're looking to discuss, if there is anything we can do. As far as the overprescribing, we are having a look. There is details on that for, there's a prescribing team. We're actually going to work with them to kind of see if there's anything we can do. We're looking at increasing the social prescribing. I think we mentioned that the last time, to kind of reduce the number of prescriptions that are issued. But again, it's like turning an oil tanker. It will take some time to get these changes through. And what was the last one? The care homes. Yeah, the payment to the care homes. Although the payments seem high for this year, they're actually dropping off. We're not even £100,000 a month now for all the claims that are coming in. The amounts in here are from right back to the beginning. So we're providing for everything. It's like for the last 3 years. So the month-on-month payments that are coming through are way under £100,000. So it's the ongoing effect is going to be minimal. And the team have been working with the providers to soften this blow coming forward. So they know they've been working on it. They know it's stopping as of the March. So they've been taking steps to kind of counteract that as well.
Okay, thanks, Paul. And I think on the prescribing and the social prescribing, it's almost, I suppose it's almost a national discussion maybe about how, I know general practice, we know it's under a lot of pressure and people are going expect, it's a quick thing, isn't it, to just prescribe something quickly. So I absolutely get that's bigger than just Aberdeen, but good to hear these discussions are happening, and maybe something that we can look at in our next year's delivery plan about how we get more around the social prescribing bit as well. But thank you. I'm happy with those responses. Thanks, Paul.
Thanks, Luann. John.
Yeah, I think basically Paul's kind of answered most of my question, which was on the back of Luann's question about prescribing. But it'd be just interesting to get back from the meeting you're going to later, Paul. In terms of the average price going up, are we talking there about, or to what extent are we talking about increases in the price of generics, which are basically a commodity? Or are we talking about GPs prescribing more modern branded medicines, which are necessarily going to be more expensive? And in terms of the volume of prescribing going up, I'm kind of wondering, is that related to the fact that during lockdown, people were not going to the GP, the people weren't going to the GP, so they weren't getting a prescription, whereas now that kind of unmet demand is kind of catching up to what it would have been otherwise? So yeah, not expecting an answer now, but it'd be just interesting to get the answer to some of that from your meeting. And I think the other thing I have in mind is that I think traditionally in Grampian, we've been quite good on prescribing in terms of quite high levels of generic prescribing, quite good at not prescribing drugs of limited clinical value. So yeah, just interested to know about those things. And I guess if I'm being pessimistic, it's if we're actually quite good at prescribing already, what is the scope to try and reduce that and keep that down? So yeah, if we could bring that back from the meeting later today, that'd be good.
Yep. Okay.
Yeah, thanks for that. I completely agree. I think it would be useful to get some information, some indication of the direction for prescribing in the future. And I think we're all agreed that it is really preferable to start looking for alternative methods along the social prescribing routes. So more of that. Obviously, it's more of a national strategy that would be required, but I think that's a direction that we really need to go down. Just looking at Appendix F, that's quite straightforward. Is there anything to add on F about the environment, Paul? Because we're being asked to approve that. I think it's straightforward. Anything additional there?
F is purely just a tidying up. We're just moving it about with the debits and credits, but it is purely a tidy up exercise. There's nothing untoward in there.
Yeah. Okay. Are we content to agree the recommendations to note and approve as suggested in the recommendations? We're okay with that. Okay, that's great. Thank you very much, Paul. Thanks for your help there. And we can move on to 4.1, board assurance and escalation framework. We go back in the agenda, and I think this is Martin Allen, isn't it?
Yeah, thanks, Chair. Yeah, so the committee had before it the annual review of the IJB's board assurance and escalation framework. The framework describes the regulatory framework of the IJB to support its visions, values and principles. The details in the appendix illustrate the landscape in which the IJB operates. For example, the committee structure, terms of reference, the risk assessment system, the risk escalation process, and the clinical and care governance framework. The framework was formally approved by the IJB in 2016 and has been annually reviewed since then. The 2023 review has been undertaken and the revised version is attached to the appendix to this report. The main changes to the framework are in relation to updating the document to reflect the current strategic plan, as well as changes made to the terms of reference of the partnership senior leadership team and job titles. The IJB will receive a revised scheme of governance at its meeting in April 2023. And within this document will be proposed revisions to the terms of reference to the IJB and its committees. And it's proposed that once the IJB approves the revised scheme of governance, that the framework be updated to reflect any changes to the scheme. It is proposed that the framework continue to be reviewed on an annual basis. And I'm happy to take any questions on the report. Thank you.
Okay, thank you very much for that, Martin. I get a great deal of reassurance from this framework. There's a very robust methodology that's been put in place to make sure that it's a responsive structure of governance. There's mention in there. There's mention of the governance groups and the local empowerment groups. There's also mention of the engagement officer. So I think that that's really helpful. That it's an outward looking plan. It's not just about organizational aspects. Could I just ask about the engagement actions? That's being built in, and that will involve consulting, methodically consulting groups and so forth. Is that correct?
Yes, that's correct. I see Alison McLeod's on the call. I don't know whether she would have a little bit more detail on the engagement side of the process, but that would be my understanding. Yes.
Yeah.
You happy to come in?
Yeah. Yes, please.
Yeah, we appointed an engagement officer. We have always had an engagement officer in our structure, but the position was vacant for some time. So now that Matt has started towards the end of November, we'll reinvigorate our efforts in terms of engagement. But absolutely, we have our guidance for public engagement, which the IJB approved, I think May 21 or August 2021, a little while ago anyway. And we are sort of dusting that off and updating it in relation to the most recent updates in terms of community empowerment and engagement. And Matt will be ensuring that all staff are aware of the policy, and that we are embedding that in everything that we do, and ensuring that we've got that robust framework for engaging with all our stakeholders and ensuring voices are heard, and that they influence service design and delivery.
Great. Thanks very much. Thanks very much for that. I mean, there's quite a push towards involvement of localities, the locality groups, and so forth. So hopefully this is an opportunity to really develop that engagement of reaching out and listening to people, and not just listening, but also feeding back to them, because there are considerable risks around perceptions, public perceptions and expectations, and I think that there's quite a lot of work to be done with looking out from the organisation and providing reassurance that we're managing risks, and that there is a very strong governance structure in place. Good. Does anyone have any questions on this item? Luann.
Thank you. I suppose when I was reading it through, I was thinking about what the risks that have been escalated, through clinical care governance recently, and some of the risks that affect our ability to deliver are actually risks that sit with our partner organisations, such as NHS Grampian, and at the moment, the way that the risk escalation framework is presented, it's looking at everything internally up to the IJB, including engagement, which is really important, but it doesn't make explicit how we escalate things to and from our partner organisations. So I wonder if that's something for how we go forward and develop that much more collaborative governance approach across our whole system. Not to change what's in this one, but just think about the year ahead.
Yeah, no, thanks for that question. Later on in the agenda, there's an audit on data sharing. One of the recommendations in that is in relation to undertaking a assurance mapping process, just to kind of understand all the kind of controls and mitigating actions that are already in place within the partners in terms of the council and NHS Grampian. Just to then provide the assurance to the senior leadership team and also this committee and the IJB. So I'm wondering if that's a process we could be using in other areas to kind of help just get that assurance across the piece, specifically in relation to areas that are out with the direct control of the IJB.
Thanks, Martin. Can I come back in?
Please do.
Thanks. Just also connected to that, I think just to highlight that NHS Grampian have set up a short life working group, which will be chaired by Nick Fluck, and that's looking at what we mean by collaborative governance and trying to get a bit of a clear definition of what that is. And once that work is completed, the intention will be to have deeper conversations with partners such as our IJBs around how we get that right, and who's escalating to who, and how we make that as straightforward as possible, not duplicating and making sure we're not missing anything, but also not creating loads more work for anybody either. So just to flag that work's a way to start, as I understand, and I'm going to be around that, so we'll make sure that we're linked in from an IJB perspective as well.
Good. Thanks very much for that. I mean, and I think so. This document's coming back. So it's an ongoing, evolving document. So hopefully, these points about developing, strengthening the collaboration with partners and with the public, all of that, I'm sure, can be incorporated in some way as we move forward. It's going to the framework's going to continue to evolve. So I think that's all very positive. So are you okay with that, Luann? You're happy with the answers?
Yeah.
Okay.
I'm not seeking to change the recommendations. We can maybe just capture in the minute that that's the kind of themes that we've spoken about. Yeah.
Great, thank you. Okay, so can we agree the recommendations in that case for 4.1? Okay, and that's fine, thank you. Okay, let's move on to the next item. Next, so who is introducing our next paper?
Myself, Chair.
Okay, thank you.
So thank you, Chair. I'm here today to present and seek approval for the internal audit plan for 23-26. Where it is a 3-year plan, and I welcome any comments on the whole report, my focus will be on the next year, so 23-24. The plan will then be reassessed each year as we look to always make sure we have a 3-year rolling programme of work. The work for this plan started back in October, and in terms of plan development, the document sets out the consultation process that I've went through, including discussion with stakeholders, review of previous work, engagement of other assurance providers, and benchmarking against other IJBs. The result is what I think is a very balanced plan. It is one that addresses the core functions of assurance, but also has wider pieces of value-adding work. So here today to answer any questions and hopefully receive your approval. Just a final few housekeeping points from me though. In terms of timings, if the plan is agreed by committee, I'll then reach out to officers and agree the timings for individual reviews. This will look at matching internal audit resource, but also recognising the business as usual and other commitments on the IJB and its partners. The plan includes 1 or 2 lines on the high-level scope for each review. I don't intend, and I won't be in a position today to go into depth about the actual full scopes of reviews. This will come as part of the scoping and planning process before each audit. And the last thing, and I'll try and keep a straight face when I say this very cheesy line, internal audit is not a science, it's an art. How I do a plan is different from how John or Alan or Luann would do a plan. It's different from how a councillor would do a plan. There's no perfect answer. It just has to be as considerate as possible, and I've covered all the work that I've done to make sure that it is. Thank you, and I welcome any questions.
Great, thanks very much, Jamie. A lot of organisation, a lot of work's gone into this, so many thanks. Luann, thanks.
I didn't know my hand was up, but maybe that is still up from the last one. Sorry.
All right.
But yes, I do have questions and comments, so that's fine. Just on the, like, noting what you say, Jamie, about not getting into the detail, but can I just clarify the one about hosted? Are we looking at services that Aberdeen IJB host on behalf of Grampian, like our sexual health services, or are we looking at other IJBs hosting our services like GMEDs? Just so that I'm clear, because I read it and I just didn't quite understand it. That's my first question.
Thank you, Chair. The intention would be the former. So
Okay.
the services, so for
So it's what
example,
we
mental
do.
health, sexual health services, specialist older adults, things like that.
Good. Yeah, that makes sense. My second one on the complaints handling is more sort of what I would like to see. So it's maybe not going to be in the scope, but so I get that you're looking at the process around complaints handling, but is there going to be within the scope to look at like the quality of how people have experienced our complaints handling process? Because for me, that's really what matters. And the kind of thing I'm interested in is, are we being person-centred? Are we being trauma-informed in how we communicate and the language we use and how people experience making a complaint and getting that resolved satisfactorily? I know that's kind of a big area, but that's what I'm really interested in.
Thank you, Chair. No, and it's great to have that feeding into the scope of the review. So with this review, the intention would be to look at all complaints that are received by the IGB, whether they start in Aberdeen City, NHS Grampian, or directly to the board. And certainly, I would envisage an aspect of that scope would be to look at the quality of responses. So I think you'd said making sure the responses were person-led and we focused on the complainant. Absolutely things that we would look to scope into the review.
Okay, that's great. And final thing from me was just something I noticed in the plan, that the internal audit is either IJB or Aberdeen City Council, you know, down in the column, and just wondered, does that create a gap? Should NHS Grampian feature or not? Like just a genuine, just what I noticed when looking at the table.
Thank you very much. Yes, absolutely. So as part of my annual opinion, I look at the work that's carried out by NHS Grampian's internal auditors, so PwC, and I also meet with their Chief Internal Auditor, Gillian Collins, on a regular basis. But in terms of actually being able to include or instruct NHS Grampian, I don't have that authority, so I couldn't include it in my plan, but I certainly consider the results as part of my annual opinion.
Thank you very much. Yeah, could I ask about the section that mentions benchmarking? There is a comparison with other IJBs, and I'm just wondering if it's possible to give us a little indication as to, you know, as to the value of doing that, because it's always useful to learn from the experience of others. Sometimes you have, sometimes you're able to be more productive, so the comparison is of less value. I just wondered if there was any, you know, what kind of use is there with benchmarking to ensure that we're maintaining quality, so that we've got the high standards. Mindful that next year, budget setting, monitoring, and NCS would be the subject of assessment. So I mean, with the first one, there will be an enormous amount of variation, so difficult to compare how they function. And then the other one, the NCS, that's something very speculative. So again, another set of challenges. So the comparison would be very difficult there. Any thoughts on that?
Thank you, Chair, and I apologise if it doesn't come through clear enough in the report. I'm not saying that our results or our performance should be benchmarked. What I'm saying is part of developing the plan, I looked at the plans of other IJBs across Scotland to see the reviews that they were doing, and again, not to copy their homework or see what they're doing and just say, okay, we'll do that within Aberdeen City, but it was to identify, do you know what, are there any other areas out there that are auditable for Aberdeen City? And actually, when I looked at the plans, we were very comparable. So the two things which actually came up in most plans going forward for IGBs were the National Care Service and were things around medium-term financial strategy, budget setting, and I was already pleased to see we already had that in our plan.
That's helpful. Thank you. Interesting to see that all the IJBs are clearly sharing similar thoughts. All going through very similar experiences and challenges. So I suppose it's just makes sense. It's almost predictable that they will be investigating similar areas of business. Thanks very much, Paul. Any other questions? Okay. I'm happy to approve that. Yeah.
Sorry,
Okay.
Martin, just sorry, I don't know what's happening with my hand this morning. I had just one other thought to ask Jamie about. I'm aware other areas have looked at their ADPs and their structures, and whilst I'm not asking that we have that on our plan, but I'm interested in just the decision making about why we're not doing that. Just to understand that a little bit. Thank you.
Thank you very much. Yes, our local authorities are or IJBs are looking at their ADP, and as the Chief Internal Auditor for the Aberdeenshire IGB, that was a review actually carried out this year. The results of that were shared with the Aberdeen City IGB for kind of best practice and lessons learning, but through discussions with the Chief Officer, it was advised that any help we could do would maybe more an advisory management assurance piece, and they seen the other areas as more value adding in the report. So definitely something we've spoke about, definitely something I'm able to help with going forward, even though it's not in the plan.
Thanks very much. So 5.1, we're content with 5.1. Yeah, great. Thanks for that. Going on to 5.2. Still with yourself, Jamie.
Thank you, Chair. This is our standard report providing the committee with updates on the delivery of the internal audit plan, as well as follow-up of internal audit recommendations. With regards to the actual contents of the report, you will see from the progress section that we continue to close off audit reviews, with 2 being presented to the committee today. With regards to the follow-up of recommendations, as at the 30th of December, there were 3 due, and management has closed off 2, leaving 1 to be carried forward with future recommendations. Thank you and welcome any questions.
Thanks very much for that. Any questions on 5.2? I think everybody's content with that. It's very straightforward. John.
Yeah, sorry, just very briefly on the one that hasn't been closed off. Would I be right in assuming that it's well on track, so it's just a case of some I's to be dotted, some T's to be crossed, rather than anything particular to worry about?
Thank you, Chair. So yeah, definitely work in progress by the service, but we do have Paul here, who is the action owner for that, if you want to give an update.
Yeah, it is on track. This one's just a pure capacity one with the budget and the year end. To detail the budget into the delivery plan will take a considerable bit of work to do that, breaking down the budget into the component parts. So we've asked for a deferral up to the end of June, which is the first round of monitoring. So it'll be in by the first round of monitoring in June.
Fine. No, that was it. That's great. Thank you. I'm reassured.
Great. So everyone happy with that report? Yeah, great. Thanks very much. 5.3 transformation now. Jamie.
Thank you, Chair. The objective of this audit was to provide assurance that the IJB is continuing to make progress with delivery of its transformation agenda. Despite a number of challenges facing health and social care partnerships, so not just Aberdeen City, I'm pleased to say that we've been able to take assurance that work is continuing to progress delivery of the transformation agenda. To support this work, we've made a series of recommendations to guide management, and these include formalising the project management process, enhancements to plan project reporting, the completion of relevant training by staff, and enhanced monitoring of risks and finances. I'm pleased to say that management has agreed to all and will implement these as part of a time-bound action plan. Thank you and welcome any questions.
Okay, thank you very much. Huge challenges with various public sector pressures, resource pressures, cost pressures, and so forth. So transformation is even more important than previously. Anyone got any questions on this? I think it's fairly straightforward. John?
Yeah, it's just really a benchmarking question. Would it be fair to say that in terms of transformation, we're kind of in the top half of the league in terms of moving forward compared to other IJBs?
Thank you, Chair. I wouldn't have all the data unless the service had information. However, from discussions with other chief internal auditors, I didn't have concerns with the progress of our transformation agenda.
Thanks.
Okay. Thank you. And Luann?
Thanks. I think you've probably just answered it, but I suppose when I read it, thinking when you looked at 5 areas, 2 of the areas didn't have the robust plans and somebody taking a lead on it. I suppose I'm just looking for assurance, and it's maybe through Paul or through Alison. If we were to look at all the areas, you know, what we really want is to make sure that each area has got, you know, someone responsible for it in a clear action plan. So just looking for assurance that this is just a moment in time, and yeah, as we go forward, that, you know, we're not going to be missing any key areas. Thank you.
I think Alison might be able to help. Thanks.
I hope so. Thank you. Yeah, I think a part of the issue, Luann, obviously, was we were very reactive over the COVID period in particular. And a lot of the projects that we were dealing with were more sort of almost business as usual projects, if you like. I think one of the projects that we looked at was delivering mental health and wellbeing initiatives to staff, which is something that we wouldn't necessarily have a full suite of project documentation for. As I say, we had some funding and we just reacted to delivering that. So what we're doing going forward in our delivery plan is categorising the projects in there, those that are full transformation projects and those that are more business as usual, and hopefully that will what we're seeing is that if something that we're doing is a full transformation project, then absolutely we would expect to have the full suite of project documentation and all the sort of checks and balances that go along with that, and that will hopefully direct future audit activity to those what we would call sort of proper transformation projects. So I don't know if that answers your question, Luann. Hopefully I'm on the right lines there.
Thanks, Alison. It does, and yeah, it's the COVID context, I think, that we're coming out of and needing to work through. I suppose my final comment would be on that report, given that there was a number of areas, as Jamie has outlined, where there was audit concern. I'm wondering if we should just have a time or a place that we formally close those off, so that just from a governance point of view, that we've got that assurance that that loop is closed. So whether that's just an update report to come back here or in some other way, but I think we just need to have that formalised. Thank you.
Jamie.
Thank you, Chair. So all recommendations for this report, as with all internal audit reviews, will be followed up when they come due. And in the internal audit update report that you've just had, we would flag any that had been closed, been extended, or not been taken action on.
Thanks for that.
That's great. Thank you.
Great, thank you. Yeah, I mean, transformation is very much about improving service delivery, but related to that is the efficient use of resources, and I'm wondering if our discussions about finance monitoring will relate to, you know, how will that relate to the transformation programs? Because the transformation is not driven by financial targets, but they are connected to each other. So if we're able to perhaps improve and make finance monitoring more robust, will that help us to be slightly more focused in our aspirations for transformation? And Paul, did you have your hand up?
Yeah, this kind of links back to the audit point on the last report about allocating the budgets on the delivery plan. Once we get it broken down into that, we can start putting a figure against all these projects to then monitor the finance on them.
Yeah, I think that will be helpful, just as factual information. I think that will be helpful. Great. So that's 5.3. Are we happy to agree the recommendations there? Happy to move on? Yeah. Okay. Next is 5.4 on data sharing. which is once again Jamie.
Thank you, Chair. The objective of this review was to ensure that the IJB has appropriate assurance over the arrangements and procedures for data sharing between its partners. On the whole, we've been able to take reasonable assurance over what we see as a moderate risk area, and this reflects the control framework that the IJB has put in place. We had one major finding, and that was around elements of governance in place, specifically the lack of an overarching data sharing agreement, which is yet to be signed by Aberdeen City Council. For this and our other findings around areas such as enhancing staff training and responsibilities and data management, the service has agreed to all recommendations and will take these forward as part of a time-bound action plan. Finally, it was envisaged that this review would be a joint piece of work, one that brought together similar audits within NHS Grampian, Moray Council and Aberdeenshire, and that was to present broader assurance in the region. Where the work has been completed for Moray, Aberdeenshire and now Aberdeen City, NHS Grampian and their auditors have not been able to facilitate the work due to other commitments. It is, however, still the intention to bring together all the work into an overarching executive summary, and this will be presented to committee on finalisation of the NHS Grampian review. Thank you and welcome any questions.
Thanks very much, Paul. You mentioned there the difficulties for the NHS in providing data, and that was due to, well, I presume competing demands due to the regulatory audit. I mean that's absolutely understandable, but I mean, what kind of an obstacle will that be in the future? Because obviously we want to have the information flowing through as much as possible.
Thank you, Chair. We've got Alan Bell from the service. If you'd like to bring him in, I'm sure he could give an update.
Alan. Thanks, Alan.
Yeah, so thanks for having me along. I think I'm here in two roles, one as the IJB DPO and one as NHSG DPO. I will put my NHSG hat on first and make sure I separate this appropriately. Like all health boards in Scotland, we've been subject to an audit from the Information Commissioner's Office, and the instruction from my exec lead, Nick Fluck, and actually my boss, in fairness, as our CIRO, was we had to focus on that, and absolutely we did have to focus on that. The regulator is the trumps all other things. What I would suggest is we're through that now. We're in the sort of 10-day cooling off period while we write our report, and then we get the draft report for comment. I'm quite happy, I think Nick would be too, to bring kind of the summary of that back here, if that would help assure the IJB in terms of what our position is. It was quite a thorough process, as Jamie knows over here, and I have talked about this offline. So I don't think there's a particular issue around assurance in this space, given what we've just gone through. But we weren't in a position to contribute in the way that we might have liked. What I did do though was, and thank you to Jamie for arranging this, is towards the end of his process, he and I spent quite a lot of time discussing the report, and I was able to feed certain things in as an update for colleagues. I appreciate an audit's a moment in time, but Aberdeen City Council have now signed their information sharing agreement along with the other two local authority areas. I might have some comments just in general as IJB DPO, but perhaps it would be better to let the conversation flow first, Chair, and then bring me back at the end on that, if that's okay.
Right. Okay. Thank you. I mean, what I'm hearing is that it's basically a capacity issue,
well, yes, I suppose that we can only attend to one major audit at a time. Yes, yeah. And keep the business running. So yeah, absolutely.
Yeah. Okay. Thanks for that. John.
Thanks. Yeah, it was just on this question of the agreement amongst the various partner organisations which the City Council hasn't yet signed. So is there a problem with that, or is it a case of it needs to go through a committee cycle, or it's a case of some extremely busy people just haven't got round to it yet?
It's signed. It's been done.
All right.
So it was in train when Jamie did his report. And I've had the response back from the city council. Sorry, I've been on audit time, so at some point in the last fortnight it turned up, but my attention has been elsewhere. So
I know the feeling.
Okay, thanks for that. And Luann?
Thanks. Yeah, probably just a few things. One, just a practical thing on timescales. It would be good to get that report back. So is it realistic to see that come into the next RAPC committee, or will it take a bit longer, Alan? My first question.
So I don't know if I have leave to bring the full report or the summary, or what I'll have to sort that out internally here.
Okay.
But the timeline we have at the moment is the last audit interview was Friday. Sorry, it was Thursday last week. 10 days after that, we're supposed to get the draft report. Then we have another 10 days to provide management responses, factual corrections, and to partially accept or refuse the recommendations, and complete the action plan and assign the actions. So we're probably looking at kind of 20 or so days from nowish until we get to the point where there's a final report, and then we're waiting for the ICO to issue that. What won't happen is that will be an exception report, so it won't say anything that we do well. It'll just point out where there's improvement areas, that won't be published. What will be published is a report on the data protection stance of the NHS across Scotland. They're doing all 22 boards, so that will be the published output from this. But we'll get our own exception report and action plan that we can then use to tweak our own strategy and action plan, which went through CET earlier this month and is on its way to NHSG Audit Committee quite soon, I think.
Okay, so I guess it just depends on all that. Our next meeting's in May, so we can look. My other questions are, and again, basic questions. So we've got all partners are signed up with this information sharing agreement now. So what difference does that make? Like, what does that mean? Is it
that's a piece of, think of that as a piece of infrastructure. So
okay.
what we didn't, we have lots of information sharing agreements with, as a health board, with lots of our local authority partners for lots of different activities. What Helen Cannings and I realised, Helen's the DPO for Aberdeen City Council, as I'm sure you all know, was actually this is the amount of sharing, the range of sharing, the purposes for sharing are increasing and changing constantly as the system responded to COVID and subsequently. So what Helen led on, and I'll absolutely give Helen her place here, she very much led on this, was an ISA that we could use as a framework agreement. So think of it as a framework agreement with a section in the back that we can then call off and do lighter touch information sharing agreements where we need to. So essentially there's an appendix in the back that we fill in for as we need to for different sharing activities as they come up. The idea was to provide that fundamental infrastructure around information sharing within the context of partnership, but also to try and provide a little bit of grace to when we do these information sharing agreements, because they can be long and they can be, you've seen some of them, Luann, so they can be long, they can be complicated, they can be quite difficult, and they can be quite urgent, you know, as COVID taught us. So that we're trying to get ahead of that. It's a bit like the information sharing accord between the health boards. It's not something we want to rely on to the exclusion of everything else, but it does give us a backstop for the sharing of data between different boards for the purposes of care and the management of the healthcare system and so on. We're thinking of the IJB agreement like that, that it's that fundamental backstop. So when a new project arrives, we've still got to do all the assurance, we've still got to do the DPIAs and work out what the data flows are, and is it lawful and proportionate, and all the things that people like Helen and Andy and Alison and I worry about. But when it gets to the governing instrument, we don't have to do that from scratch each time. So that's the approach that we're trying to take.
Thank you. That sounds really good. Not reinventing the wheel every time is always a good idea, isn't it? But final, I see Martin Allen's hands up. But my final question, just to finish that off, was So it relates to health and social care partnerships, but does it include the information sharing across our commissioned services? And I'm thinking of all the services we commission that are not directly employed by the partnership, and also general practice.
Right, so not quite is the short is the short answer. There are degrees of complication there. So this is the ISA that we've put in is around the integration functions for each of the three IJBs, and as you know, they're slightly different between each of the IJBs. It doesn't deal with commission services because commission services usually involve a third party doing the doing of things one way or another, either as a direct instruction from the council or from ourselves as a data processor, or a share with an equal partner. And it would be very, very difficult to develop a framework agreement, to use that term again, that would deal with that, because every set of circumstances and every set of data flows that we do in respect to commission services is different. It's bespoke. You know, alcohol and drugs might be slightly different to suicide prevention, might be slightly different to something else. So so that's not as straightforward to do. So I think we probably are still doing, you know, DPIA and governing instrument for whatever partnership that we've commissioned. GPs is a different level of complication again. There are I think 69 independent GPs in our area. The number fluctuates a little bit depending on whether they're 2C or not at any given point. They are all independent data controllers in their own right, as you probably all know, and responsible for their own rights, obligations and liabilities under data protection legislation. So what we do to support those from the health board is we provide the GP DPO service, which is quite hard to say with my accent, and they access DPO services from the board under a MOU, and we've got primary care contracts manage that. We've got an MOU with all of the independent GPs. That makes the flow of data between the GPs and the board relatively straightforward. Relatively. What it doesn't do is deal with that next step within the partnership with the council. So we have to make a decision then. Is this data we jointly control with the GPs? You know, they've given us something and it's in our systems, therefore can we then onward share within the context of partnership? So that there are kind of ways we do this. It's just extra steps because our GP partners are jointly and sometimes variously responsible for the data in their own systems. So that's an area of complexity around what is a complex system, as we all know.
I think Martin Allen wishes to come in.
Yeah, thanks, Chair. I was just going back to the discussion around the protocol, the signed protocol, and what we were talking about in the board assurance escalation framework and that assurance mapping process. I would see that protocol as being one of the sources of assurance that we could map. So it's a good kind of timely intervention there. And as I said, it's in the internal audit recommendations to do that assurance mapping process. Thank you.
Good. That's an important tie-in. Thanks. Luann?
Thanks, and I'm absolutely recognising I'm off on a tangent, but it is connected. I suppose we are really trying to be a whole system and work together and not have boundaries that prevent transformation and change. You know, we want to deliver the best we can for people. And I just wondered, Alan, would it be fair to say that the regulation around this is quite a barrier for being able to do that transformation quickly? And I just wondered if there's any sort of thinking group around how we can do this better so that we deliver the best for people, regardless of whether it's commissioned by the health board or, like, you know, just how can we get this better whilst not breaching regulation? Of course.
Right. Yeah. So the bit at the end is quite important. But the I think. Okay, so I'm always cautious around this idea of a barrier. And I realise this is going to sound defensive, and I genuinely don't mean it to. But I think if we cast this as a barrier, we almost create one. the legislation doesn't stop us doing anything. It just makes us do some things in a kind of coordinated and proper and appropriate way. And if I extend the do no harm metaphor from clinical care into data, it's very similar. The idea is that we don't want to do anything that could harm our population. That's always my starting point with this. And it's a little bit like saying, and this is a terrible example, but it's a little bit like saying if we didn't wash the instruments and wash the theatres between and clean the theatres between operations, we could maybe do 2 or 3 extra operations a day and improve the throughput. But you wouldn't want to operate on somebody with a dirty scalpel. It wouldn't be legal, ethical, all the rest of it. So it's a rotten example, but it's that thing about where it gives us the boundaries around safety and appropriateness and protection. Yes, we want to work as a system. I think we've made great strides towards that, and I think a lot of the portfolio work has helped with that, and is helping with that. And we've done an awful lot of work around system integration. I think the information sharing agreement's a really good example of that. Actually, not to harp on about it, but I think Helen's work around that is something I'm hugely supportive of. Responsiveness is a slightly different question, Luan, because responsiveness isn't just about legislative compliance. Responsiveness is about system understanding, the ability of colleagues to be able to do the work, the situation we find ourselves in. Occasionally you'll say to people, right, okay, where does the data go? Oh, we don't know. And then there's you go down a rabbit hole of complexity. That Nick uses the surgical robot as a really good example of that, the Mako robot, which you might know about, where we bought this brilliant thing to do orthopedic surgery. If you're an orthopedic surgeon, you want to use the best tool you can to get the best outcome for the patients. But then we look at that and how does it work? Well, it needs to be programmed in a particular way, right? How do we get it to be programmed in a particular way? Well, we've got to analyze a scan, right? How do we analyze the scan? Oh, the scan has to go off to America so we can program the thing so it can come back so we can do the stuff. And then there's an overseas data transfer there, and then there's a level of complexity that we didn't think about. Now we can solve all this, but that's the sort of how you go down the rabbit hole quite quickly with something that seems relatively straightforward, in as much as we want to spend a lot of money to get better outcomes for our patients with this particular robot, and then it rolls on from there. So that's just one example. So complexity, capacity in the system for colleagues to understand what they're doing, not just in our team, and then relationships. I'm not making excuses. I'm just suggesting that the legislation itself isn't necessarily a barrier. It's a set of principles and guidelines and frameworks like everything else, and that system responsiveness is actually a slightly different question, and we can do what we can to improve that, and we should do what we can to improve that, and I'm hugely supportive of that. And June's just appeared on my screen, so I'm going to pick on June because I supported Nick at a session for our CET tail end of last year, and there's lots of kind of changes coming from that in CET. I know we're discussing that around deputy silos and information asset owners and improving visibility around the system, and we're all hugely engaged with that, and it's been part of the audit that we've just done. So there are things we can do, but I don't think there's a magic one. There will always be capacity against ambition, against competing priorities, against everything else, like there is in so many of our assurance functions, not just the one that I work in.
Many thanks for that. I think that's been a really good discussion. And there's a lot for us to learn there. So thank you very much.
Martin, could I just offer a comment quickly as IJB DPO rather than NHS Grampian DPO, just because I've got to be clear about that when I'm doing this. The audit report is extremely helpful. Martin and I are already talking about how we'll bring forward that assurance. What I feel I have to say to the IJB and to colleagues here is the IJB controls a very limited amount of data directly as a data controller, and has a very fixed window in terms of where it has those rights and obligations. Whilst I accept entirely that you would like additional assurance and that's part of cross-system working, I've got no issue with that at all. I would counsel caution in crossing those boundaries between the organisations, because then the IJB will take on, or potentially will take on, rights and obligations around things that it doesn't have direct data controllership or responsibilities for, or direct agency for. And I think there's a real balance there between you receiving assurance and exercising control. And I think that is something that we, as the IJB, I feel you will wish to be quite considered around as you move forward with this process. I think the matter under discussion here is how do you take assurance, not how do you exercise responsibility and control. And I think that is a subtle but very important distinction around this, given the rights and obligations and liabilities that go along with being a data controller. So I just wanted to offer that as a thought, with the IJB hat firmly on before we move forward.
Okay, thanks for that. I mean, that's really helpful to point out that very precise distinction between the two roles. But I think the IJB can seek assurance by encouraging and promoting partnership amongst our various organisations, and I think that's something that we would want to see for the benefit of all. I think sometimes there are barriers, and sometimes they're artificial. So I think that it's quite positive when we're being as robust as we can, and in an appropriate way, in encouraging, and it's about trying to empower the organisations and expand their functions in a way that we're all where we're all on board and traveling in the same direction. So, but your point's well made, and it's noted. Many thanks for that. I think data sharing is absolutely the foundation of just about everything that we do. So it's right to give it quite a considerable amount of attention. So thanks for that. So that was 5.4. Everybody content with us to move on from 5.4? Thanks everyone for contributing. That was a really helpful discussion there. I think we're on to our last item, which is, well, our penultimate, 6.2, the strategic plan, the delivery plan, Q3 update, which is on page 105. And who is leading on this? Is this yourself, Alison?
Yes, I'll
Yes,
introduce
Alison.
this one, but I have Michelle Grant with me if we need any help with answering questions. So as highlighted at the last meeting, this report presents updates on progress against our year 1 delivery plan projects. And it's presented in the same format as we provide monthly to the senior leadership team. And this is in line with the recommendation from internal audit, as we discussed earlier. The projects are listed with what we call a brag status. So blue is for complete, red is those that are not on track, amber for those that perhaps have a concern around them, and green for being on track, basically. So the brag status is there along with text updates. The updates in this version of the spreadsheet take cognizance of the fact that the papers for risk audit and performance are in the public domain. The cover report draws attention to the rationale for some of the timescale extensions agreed. And we also have Appendix B, which is the dashboard, which is as usually is presented in this format to the committee. In line with the annual review agreed as part of the approval of the strategic plan, the senior leadership team have recently undertaken work to rationalise, refocus and update the projects that are carrying forward into year 2 of the delivery plan. And the results of this review will be presented to the IJB at its meeting in March, as part of the approval of the medium-term financial framework, because the two are inextricably linked, obviously. It should be noted that we're also undertaking a review of the dashboard. So again, just part of that refocusing and trying to understand just exactly what the performance measures are that are most important to demonstrating performance, and also those that will absolutely give us that information as to whether we are performing the way that we would like to. This review is just being completed this month, and well, sorry, March, not quite this month. And we would hope that when we bring our updates to the next Risk Audit and Performance Committee, that we will have a revised dashboard to present at that time. So happy to take any questions.
Okay. Thank you very much. It is really helpful to have this quite detailed overview of so many operational areas and where they're at. I mean, there are so many questions to ask about many of these lines, but it's particularly useful to have this to hand. I think the graphics are really helpful. I think the layout, the format provides the information in a really clear, precise and accessible way. So, you know, it's a really helpful document. Do we have any particular questions on this paper? Anybody got anything they wish to raise? Luann.
Thanks. I've probably got layers of things to speak about. I suppose the first thing to say is that I really thought it was helpful to see everything summarised like that with the brag status. That was really good for my brain to just see it all in its entirety. I wondered just what's been the learning from the last wee while about how we're presenting this, and how's that going to be in the 23-24 plan was one thing. One bit that I would be interested in is, are you thinking about for RAPC in future, maybe taking a couple of areas and showcasing either a project, an area that's completed, or an area where there's a bit of challenge, you know, so that we're getting a bit deeper into some of them? Would be one comment. And then final bit on that, I noticed the carer strategy's in as a completed thing because we've got the strategy now, but should we not then have, like, so what next? And or is that business as usual? But I just would expect to see that in there. But so that's my initial comments on the kind of what's presented in the process. I'll stop for a bit.
Thanks, Luann. So absolutely, we have learned a lot from our first year of providing these updates, and I guess one of the key things which you will see a change in going forward. Initially, as I alluded to earlier on, you know, we have categorised our projects as either business as usual or full transformation projects. So we'll split these out by category. We are also going to present the updates on the projects within a programme. So we've pulled a number of relevant projects into programmes. So we've got a programme for all the commissioning work, for instance. We've got a programme for all the prevention work. So we think that will be, as you can see, there's a fair number of projects on the list. And whilst it's great to see the categorisation of those that are red, amber, green, whatever, we felt it might make it easier to assess performance, if you like, if they were pulled into these programs of delivery. So we hadn't, to answer your question around about the deeper dive, that wasn't something we had considered, but it is absolutely something if the committee was of a mind to do that, you know, perhaps for our quarterly performance reporting going forward, you know, we could focus in on a particular program, so that would be a group of projects, and just have a look at that performance and anything that any issues that we're encountering with delivery, etc. Happy to do that.
John.
Thanks. Yeah, and like others, I actually found the format really helpful. Although you'll be annoyed that because you've given me some graphs, I'm going to ask some questions about the graphs. Sorry about that. The two that stuck out for me a bit were page 121 of the pack, the figures on delayed discharges. I'm just wondering what's going on there. Why is it going up from what it was, and what can we do about it, is the first question.
So I think in essence, the reason for the increase is just the sheer pressure on the system. You know, we've got more folks coming in. We've got a higher level of acuity, I would say. So they're sort of staying longer in hospital. And also we've got the pressure on our community services. So, you know, there is a kind of almost a maximum capacity, if you like, whilst our arrangement with Granite Care Consortium and Bonaccord Care in terms of care at home provision has actually increased our capacity. It's not increasing at a rate, same rate of demand, if you know what I mean. So it's that continually juggling process. What I would say is that delayed discharges continue to be an area of focus. We never really take our eye off the ball with delayed discharges, and you know, it has to be said that in Grampian we are actually delivering, and particularly in Aberdeen City, our performance on delayed discharges is certainly improved from across the country. I was looking at some figures the other day there that said that on average in Grampian 1%, in Aberdeen City 1% of discharges are delayed, whereas the Scottish average is 3%. You know, so in actual fact, our performance in that area it is better than the national performance. But having said that, there's still an awful lot of work to do, and a lot of our standard, you know, whilst we've made really good progress on our standard delays, the challenges for us remain with those more complex delays. So those where there, you know, housing needs adapted, or you know, where complex care facilities perhaps are just not available. And also another challenge for us is around adults with incapacity, because you know, it takes longer to move these clients on, because of all the checks and balances that need to be in place before decisions can be made around their care. So yeah, really good point, John, but I can only assure you that delayed discharges remain a huge focus for us.
Thanks, that's reassuring, and I guess it's a bit like painting the fourth bridge, really, isn't it, on this issue. I've got one further question on the next page on the pack, 122. Number of falls seems to have gone up quite a lot. I just wondered, is that just kind of like sometimes you get a higher instance, or is there something that we should be worried about?
The fall rates do fluctuate, and we find ourselves continually going, oh, we're doing well, and then, oh no, it's not so well. So there's a huge number of factors there, John, and we are certainly concerned whenever the number increases. And again, it's an area of focus for the service, just to see what exactly is going on there. You know, there's a number, you know, it's difficult to give you an exact reason as to why that's happening, but rest assured the service is looking at it, and we will put in place any arrangements that we can to ensure that we address those increasing figures.
Would you mind if I just came in there?
Thanks. Yeah, please do.
It was just to mention that's something that repeatedly comes up within the Clinical Care and Governance Committee as well. And the group there in particular quite often have a look at a deep dive of an area, looking at falls around their adverse events and the lessons being learned from them. So that's absolutely been taken into account, but reflecting, you know, I think with the group of patients that we're looking at, you just occasionally get these fluctuations.
No, thanks for that, and again, thanks. I thought really useful and very clearly set out paper that gives us lots of data. So thank you.
Okay, thanks very much for that. June.
Thank you, Martin, Alison. Thank you very much for the paper. I think it lays out the data really well. I'm just going to pick up on falls as well. I'm not assured by the response there. Is this falls? This is the amount of falls that have been in total in these in the organisation. It's not falls with harm, or is it falls with harm?
It's the ones that are reported through DATEX. So I'd have to go back and double check.
They're all reported through DATEX, yeah. So I think it'd be really good for this committee to understand the falls with harm. People are going to fall. They're in rehabilitation environments. There's a level of having to support some kind of, you know, risk taking and supporting somebody in that rehab programme. So there will be falls, and we'll never ever eradicate falls. But what are the falls with harm? These are the ones we absolutely need to eradicate. So I think if that data presented the falls with harm, and then just understand any improvement work there is associated with those, I think that would be more meaningful for this committee and to seek assurance on. I hope that's helpful.
That is helpful, June. Thanks very much for that. We'll have a look into that and see what we can bring forward for future committees.
Thanks for that intervention. Luan.
Yeah, I suppose thinking about the data, I wondered if it would be useful for future to just have a bit more of the wider context. So when I'm in an NHS committee around this, thinking about delayed discharges, I can see how City is in relation to Shire and Murray, and it just gives a bit of a context of the pressures the whole system is facing. So I wonder if that would be useful to bring that in, just so that so John, who wouldn't see that, can get that broader local picture, and well, just to give that context, it's not just we're struggling or we're changing, but to see how other areas are doing. On the falls stuff, it got me thinking about these are falls that are in hospital settings, but is there, I guess that community falls are harder to capture, but are probably really important for how we're doing and delivering our care. So I wondered if that comes through, and if we could see that, and also on that area, in that section, is SOARS still the name that we're going to be using? Because there's been so much change with Rosewell and how services are delivered. It almost feels like we're talking in old money, but I don't know if that's just me. And is there discussion about maybe changing terminology to be more up to date with what's there?
So I'll maybe just deal with that last question first, and then I'll maybe pass back to Michelle. But yes, absolutely. In terms of SOARS and the changes within the structure within the senior leadership team, we will probably change that name at some point. But what we're waiting for is the strategic review of rehabilitation, which is one of our delivery plan projects. We are going to see that through to the end and ensure that all the staff that are currently working in that area are fully consulted and engaged in terms of where that review goes and what the current SOARS service ends up looking like before we do anything radical in terms of changing the name. So absolutely, you will see that follow through at some point, Luann, but we're not planning on changing that until that work's done.
And I suppose to pick up on the community-based falls, it's something we're aware of, and they are reported through DATEX at the moment. So the likes of community nursing obviously would come in and report through DATEX any falls that have been witnessed or that they're aware of. Our challenge is how to identify that through the data, and what we can easily extract those hospital-based falls, but for some reason Health Intelligence find it more difficult to identify those community-based falls. So it's something we're aware of and working on at the moment.
Just be reminded, the delivery plan will come back at some point. Is that correct? With updates.
So we report quarterly on delivery plan to this committee. So yes, I think it's scheduled for June. Your June committee. Yeah. June.
That's great. It'll be good to see some of the ambers turning green. For example, the justice social work activities, and also the work on the family support model. I mean, these are two ambers amongst others, which are really important, and they are examples of that collaboration. Hopefully we will see that teamwork developing and strengthening, so that we are seeing greens coming through in those two areas and elsewhere. Luann.
Thank you. And I think, Alison, correct me if I'm not right here, that the delivery plan for next year will be coming to the full IJB just for awareness and for scrutiny and stuff, probably by the end of March. Would that be right? Is that, yeah.
Yeah, so we're currently working on that year 2 delivery plan, a review of the year 1, and a revamp, if you like, of the year 2, and that will come along with the medium-term financial framework to IJB meeting on the 28th of March.
Okay, that's good. A couple of questions just then on the data that we're seeing, the MEOC work, which is really important work, and I see there's been a lot of training done. Is there what's the follow-up about? So what difference has that made in terms of how people are engaging? I'd be interested to hear a bit about that. And PSIP talks about physio service. There's not been the progress because of lack of recruitment problems, and I wondered what the flex was to employ people with not physios, but I don't know, like a yoga instructor or something. Is there flexibility that the practices can use that money in a slightly different way? And then my final thing is just I was thinking about golden threads, like health inequalities, and how we see that sort of golden thread stuff coming through in these in future iterations of this. Thank you.
So in terms of MEOC, in particular, what we're doing at the minute is a LOIP project. So we're totally linked into that LOIP project, and as you know, the LOIP projects use the improvement methodology. So we're absolutely just on the point of moving on to the so what. The training's been done, and what difference has that made overall? And the next step after that, in terms of the improvement methodology, would be to scale it up to other areas. So absolutely that learning is following that improvement methodology process and is all recorded through the LOIP. But we haven't completely replicated that reporting, if you like, here, because we don't necessarily want to duplicate. But if you would find it useful to have have a copy of the LOIP reports, then we can certainly append that or circulate it to the committee, whichever you would prefer. In terms of the PSIP physios, I'm not 100% sure on that detail, so I'd need to sort of go and have a look at that in terms of you know, what whether we're restricted in the funding. So I can't answer that part of the question. But what we are looking at in other areas of the delivery plan is that those kind of community alternatives, if you like, you know, to our mainstream services, and whilst you know, we can't necessarily replace a physio, but we can look at some sort of rehabilitation exercises or whatever through with Sport Aberdeen, etc. So there's a lot of community-based activity in terms of particularly those who are maybe having to wait longer for an appointment than we would like. We're trying to identify and signpost them to other services in the community, which will at least help maintain their condition rather than it getting any worse. Although in a lot of cases, you know, I'm sure we're seeing some improvements there as well. And in terms of inequalities, I'm not entirely sure what is it you're expecting to see through our reporting here in terms of inequalities. What did you have in mind there, Luann? Sorry.
So I don't have a fixed thing in mind. I suppose I see inequalities as being just a key part of how we're doing all these things. So I suppose it's just how do we see the kind of the net total of all that coming through. I just sometimes think with golden threads like that we miss them because we're focusing on the detail. So maybe it's a separate report, but it just, I suppose I'm just wanting assurance that health inequalities is considered through all these different areas, and there's a way of drawing that out in some report, or that's kind of what I'm getting at.
Yeah, so a lot of our prevention activity in particular is around about, is targeted at people with health inequalities. And I guess what we haven't been as good at up until now is actually gathering that data, you know, around about, you know, what are the people who are, we try and focus on areas of deprivation in terms of where we do a lot of that activity, but in terms of actually recording participants and ensure, you know, their perhaps category of inequality, if you like, you know, that's maybe not what we're, you know, we haven't reported on that. So maybe we can have a little think, let us take that away and see what we can do to try and bring that more to the fore in terms of our reporting.
Okay, and it's maybe not about data so much, but just each program being able to say, this is how we are making sure we're not excluding people or something, you know, it's maybe not, yeah, it's not necessarily about stats and data, but just the approach that's been taken and how inclusive it is and how that's been thought about in the planning. I hope that helps a bit.
Okay, thank you very much. 6.2, are we happy to agree the recommendations there? Everything noted? Good. And we can move on. There's 7.1, there's no exempt or confidential business. And 8.1 is the date of the next meeting, 2nd of May, and future meetings. So hopefully those are all in our diaries. Thank you, everyone. I think it's been a really good, productive meeting. We've had some really positive discussions. So thank you all. Thanks everyone. Many thanks for the meeting, and all the best for the rest of the day. Thank you.
Cheerio.
Bye now.
Thank you.
Thank you. Bye.
Thanks. Bye.